and I want to tell you a little bit about them before we get started. So I want to first of all thank Dr. Berman and Dr. Al-Khulumre for preparing this information in a time when we have so many questions and everybody's talking about this. Just to give you a little background, Dr. Al-Khulumre is a Hoag doctor. He's also a JCC member. His medical internship and residency was at USC, and he stayed on the faculty there and joined the emergency department staff at Hoag Hospital in 1986, where he met superstar internist Dr. Berman. Since 1987, he's been one of the physician administrators of the ER, and he served as emergency department chairman and has been on multiple hospital committees, including medical executive committee, and currently on the hospital's board of directors, a position held in the past by Dr. Berman. Dr. Berman is a JCC member of the board of directors. He graduated from Brown University and Temple University School of Medicine. He did his internal medicine residency at UCI Medical Center, and his internal medicine private practice was in Newport Beach for 34 years, and now he is retired. So please welcome them, and thank you so much for providing us with this information. So we will start, I believe, with
I'll start, Jerry.
doctors.
I'll
Okay.
start. I'll start.
And are we going to spotlight, or are we going to? You can go to spotlight or view. Lerone might be able to get that on for you. If not, we can just go for just go to the gallery view and switch it to speaker view, and then you'll get a big picture of Dr. Berman.
Thank you,
Okay.
Jerry. Thank you very much for the introduction, and welcome everybody. This is the second part program of our series that we had. First one was a couple of months ago, and today we really want to discuss several issues in regards to COVID. Hopefully over the course of the time we'll get through some testing issues, treatment issues, the vaccines, talk about our variants, and have as much time as we need for question and answering. I'm going to basically serve more as the moderator, and Eric will give you most of the information, and I'll sort of put my 2 cents in here and there as we go along. So as many of you know, Eric Al-Khulumre has been in the forefront of COVID information over the past year, and he has a Facebook post that he has, and we thought that we would start with Eric giving you a sort of a brief inside look at the process that he does in putting together his daily Facebook posts. So Eric, you're on.
Morning. Hi, everybody. Thanks for joining us, and thanks, Jim. It's good to see you. And again, you retired way too soon. We still need you to be able to do this with you. I'm going to share my screen, and I'm just going to do this very briefly and just let you know that the information I'm sharing with you is publicly available, and these are really good sources for you to be able to get things. This is from my post this morning. I'm going to try and pull it up here. It's opening. Give me a sec. There we go. Okay. Is that showing up? Can I see that?
Yes.
Yes.
So basically, so much information is available online, and it's good information, and it really helps guide us. I think a lot of it is scary, but a lot of it is reassuring when you look at it in context. So I'm going to go to a few of these websites, but just to show you a few highlights. If you see up here, this is from the Athena website, and as you can see, except I can't see, somebody's blocking me there. There we go. These are the number of patients vaccinated. These are the number of people still waiting for appointments. So if you add these together, we're looking at a little over 250,000 people who are in the pipeline of either having received or getting the vaccine, but another 566,000, or a total of 566,000 have registered. So we're not even at half of the people who want to get the vaccine have the ability to receive it because the supplies are still so low. A lot of that is going to change. These numbers, I'm going to take you to these websites specifically here in just a second. So let me get out of this, and I'm going to start where I usually start, and that is to look at the CDC website. So let's see. So we're going to go to cdc.gov, and this is it's actually a very good website. It's easy to navigate. Actually, I'm going to get rid of this here on the side too. There. Okay. I have a little more screen to work with. And as you go to the COVID section, you can see there's a lot of useful information. A lot of the questions we're probably going to talk about today in terms of vaccines. There's a new pharmacy program that President Biden introduced yesterday where vaccines are going to be available to you through your pharmacies if you can't get them through the existing sources that are already out there. But what I really like looking at is the data, and you can start just looking at the US data and just real quickly. You can see the total number of cases we've had, the number of deaths, approaching 450,000, which is just tragic. And if you've read my posts, I think mostly unnecessary. But we can see here that the new cases are tracking downwards. We have almost 33 million people vaccinated already in the country. So a lot of good news in terms of heading the right direction, I hope. Then there's also information available about what's going on in states. Let me see, here we go. So if we want to look at Orange County, you can look at many places, but you can actually start here at the CDC and the information reported to them. You see there's a map down here. And if we can find little Orange County, there's San Diego. Where are we? No, it is Riverside. I know we're there. Give me a second. My fine tuning here isn't working like it was. So I'm just going to cheat. I'm just going to type it in. California, Orange County. And so just looking at 7-day averages, what's encouraging to see for the most part is that numbers are going down. In terms of new cases, as you can see here, there's a little uptick, which I'm not seeing on other graphs. I'm not sure what this means. Hopefully it's insignificant. But these, again, are 7-day averages. Deaths are going up. And as you know, the deaths follow the infections by anywhere from 2 to 3 weeks or more. We had a big surge after the holidays in terms of new cases and hospitalizations, followed by ICU admissions, and now deaths are rising, but those other numbers are going down, the percent positivity on tests, as you can see. And then the numbers that are important to me are the hospitalizations, the percent of beds used in the hospital, and ICU beds. And all those numbers are going down. So that's all good news. So that's stuff you can get on the CDC, and I encourage you guys to look at that frequently. Closer to home, we can look at California Department of Public Health websites. And that would be COVID-19, oops, not 29, 19.ca.gov. Oh, I'm having trouble because of the Zoom stuff overlying there we go. Try that. Oh, I'm sorry, that's the wrong one. Here, COVID-19.ca.gov. There we go. So again, you can see cases specific to California, over 3 million cases, 422 deaths today. And again, there are links to get to county data. The other thing that I think is actually interesting to look at here is that you can see the daily cases and deaths and the pattern. It's getting slow to load here. Sorry about that. The specific graph I want to show you is this one, where again, we're just seeing that the death counts are actually going up because of the post-holiday surge. So this is stuff we still are taking very seriously. You can also look at, on the California website, there's something called Blueprint for a Safer Economy. So we look at this pretty frequently, and it has the tier information, which I'm going to come back to in a second. And then this is the state map I really just wanted to show you. Virtually everything is purple. 99.9% of the population is still in this purple tier of widespread risk, including Orange County. Okay, just going to take you to a couple more I want to show you. Locally, we have our own Orange County Public Health Department, and you can start at ochealthinfo.com to get to their webpage. You can click into the COVID section, and you'll find information about the vaccine and who's eligible to get it and how that all works. They have links to other things, including the Othina website, which is how you get your appointments. And they tell you who they're vaccinating. And then here's that same graph I showed you with a few more people have been vaccinated since I made that last graph. So that's a good place to keep track of things if you haven't had your vaccine yet. You know, also on this page, just a couple more things I want to show you. These are the case counts. You see this graph frequently in my Facebook posts if you're following them. 53 deaths were reported locally today. Here's our hospitalizations and ICU cases. Those are going down. And then there's a link to a bunch of interesting graphics that also explain the current situation. And they're coming. Here we go. So again, here's a description of the tier system that we're currently in and how it applies to Orange County. So as you'll see in a second when these numbers get bigger, well, they're not getting bigger like they're supposed to. There they are. Okay. So we're in purple. We're in the widespread tier. And to get out of this tier 1 from widespread to substantial, when more things can start opening up, we need to change some things. So anything more than 7 new daily cases per 100,000 is going to be purple. We need to be between 4 and 7, but we're at 39. So we've got a ways to go to get our caseload down. Our positivity rate needs to be between 5 and 8%. We're at about 11% now. So we still have a ways to go. And then again, this is another graph I like to look at a lot. This is our hospitalization curve, and this is our ICU use curve, and they're both, you know, going down from this big peak we had back in late December and early January. Okay, and I'm going to show you one more graph, and I won't bore you with any more of these after that. And this one is one of my new favorites. Actually, I'm going to show you 2 more things. I'm going to show you the herd immunity graph, which I recently discovered, COVID-19-projections.com. Oh, I spelled COVID wrong. That didn't help. Sorry, the Zoom thing keeps blocking my ability to see what I'm typing. Okay, here we go. Oh, Safari can't find it. Something wrong here. Oh, I spelled projections wrong too.
Is that your education at USC, Eric, coming into play?
Berman, Dr. Berman, I'm going to ignore that. So this is a cool website. It's hard because you can see I can't see what I'm typing because this thing keeps dropping down. Anyway, COVID-19 projections, path to herd immunity. Because remember, herd immunity is what we need to get out there again without having to wear masks and be distanced. We need to have people vaccinated, and we need to have people immune so they don't pass it on and don't get sick and don't die. So the path to herd immunity is coming. Oh, here we go. So this is there's a bunch of different graphs about vaccination that they track at this website, but this is my new favorite graph to look at. So the purple at the bottom are infections. So back here at the very beginning of the graph, the only people who are immune, because there was no vaccine, were the ones who got sick. So they estimate that about 66 million people developed immunity from infection alone back in early December. But then as you can see, we started vaccinating. This blue area are people who got the vaccine. So purple is people immune from illness, blue is people immune from vaccine, and this overlay area is people who got both. They got some of their immunity because they were sick, but they still get the vaccine. So if you follow this line of total immunity out there, and it's something that's dynamic and it changes as you move, you can see as we vaccinate more people, and illness is also going down as the purple line is dropping, but we are approaching herd immunity. And the predictions are we need to be somewhere around 70% to have herd immunity. And we're probably only at around, what today was February 4th. We are February 3rd rather. We're at about 30% total immunity. And of that, only about 1% is from vaccination. The rest is all from illness. So then we get out here around June 30th, which just happened to be my birthday. We hit 69% total, and it kind of caps out in the 70 to low 70s range. So this is where we need to head. So this gives me optimism that we will be in a position to start opening up things more with more people who are vaccinated and immune from the combination of immunity from illness and vaccination. And then just the last thing I'm going to show you, and I'm not pandering, but this is from my hospital. You can get information at covid19.hoag.org. And I want you to see this because it does, for some of you, it may be your best way to eventually get your vaccine appointments, along with going through Athena and maybe the pharmacies. This is another route for you. So if you go to this web page, there's a lot of good information. There are links to some of the same sites I showed you earlier, the Orange County Healthcare Agency and CDC. But for right now, if you go to vaccine information for adults 65 plus who are in the group that can get it, you'll get to this vaccine information page, which has the link to the appointments. Unfortunately, this is what we're seeing now because there just isn't enough vaccine to make the appointments. Whew. Okay, I'm going to stop sharing my screen and turn it back to Dr. Berman.
Okay, thanks, Eric. Thanks very much. I want to move to testing, but instead of initially starting and going how you get tested, et cetera, I want to pose a question to Eric if he could answer it. And that is, what you do if you test positive for COVID, whether or not you're asymptomatic or symptomatic, when to go to the hospital if you are symptomatic, and then also about treatment with monoclonal antibodies. That's the Regeneron or the Eli Lilly antibodies that are now being given. Who is basically considered a patient that would benefit from that. And so I'll ask Eric to sort of touch on some of those issues before I get into how you actually get tested.
Okay. Yeah, it's no fun getting sick with COVID, for sure. If you do test positive, symptomatic or not, you really have to isolate. And the CDC recommendations, which you can also review in more detail at the website, are going to tell you that you need to be isolated for at least 10 days, and you can start returning back to normal without a repeat test. You don't need a repeat test, but you can return to normal if you've been at least 10 days since the onset of your infection, and you haven't had a fever for at least 24 hours without using Tylenol or ibuprofen to bring your temperature down. So you basically need to be isolated. You need to be in isolation and reduce the risk of spreading COVID to others. So it's pretty straightforward. It's not rocket science in this case. We know how the virus is spread, and so you need to stay distanced. It's not fun, but you have to do it. The reason we're not recommending, neither the CDC is recommending nor my hospital is recommending a repeat test before you come back to normal, is that some people will continue to test positive for weeks after they're no longer infectious. So we're not recommending that you go through that. If you test positive and you're in a high-risk group, then you would be eligible to receive the monoclonal antibody. And that was the miracle drug that President Trump got, which probably helped keep him from getting sick, along with other things that he got. So up until last week, we were limiting, at least at Hoag, we were limiting the monoclonal antibody to patients who were grossly overweight with a body mass index of more than 35, or people who are age 65 and older. And it isn't whether you have symptoms or not, it's just whether you test positive or not. And the point of getting the monoclonal antibody is to try and keep you from getting sick and ending up in the hospital. So we don't give it to people in the hospital, we give it to people who are at high risk we want to keep out of the hospital. Last week, we expanded the criteria to all of the categories that the FDA has approved for use for the monoclonal antibody. And I just run through them real quickly. They're, again, age 65 or older, body mass index greater than 35. If you have chronic kidney disease, if you have diabetes, if you have any type of immunosuppressive disease, or you're currently taking medications that are immunosuppressive. Younger people who are older than 55, if they have high blood pressure, cardiovascular disease, or chronic lung disease. And they're also including patients who are between the ages of 12 and 17 who have chronic respiratory conditions like asthma, for instance, or if they also have a high body mass index. So we've expanded greatly the categories that can receive the monoclonal antibody.
And Eric, can you talk about how you what the process is of getting the monoclonal antibodies?
Yeah, and different hospitals may have it set up differently. Initially, we were only giving it in the emergency department. Because of the way we have to enter orders through our computer, the only way you can actually get it is you have to come to the emergency department. We're not really happy about that, and not all of our patients are either, because you may see your doctor in an office, you may get a positive test, and he can't just order it for you. It's got a lot to do with the way it's distributed, partly through the hospital system that Hoag has been affiliated with, and partly the way it's distributed nationally. But so essentially, when you have your positive test, you come to the emergency department, you'll be isolated and screened, and then we've set up a special clinic that you can go to, so you don't have to sit in the emergency department. You don't need to be retested if you have your positive test from anywhere. Then we'll go ahead and use that as evidence that you have COVID, and we'll treat you. And you want to get it as soon as possible. We don't give it to people who are more than 10 days past the time they were diagnosed. So within the first 10 days of your symptoms is when you want to get it. So if you come in, we'll usually schedule you for a clinic appointment in our antibody clinic within a day or two.
And can you just comment briefly on if you test positive and you're not, let's say you're not getting monoclonal antibodies, when do you come to the emergency room? What's the criteria for coming to the emergency room?
That's a good question. And we've struggled with like who ends up being admitted after they do come to the emergency department. Throughout the whole pandemic, people last spring were getting sick, and we're just seeing our first handful of cases. We were admitting everybody and isolating everybody, and it was scary and terrible. But we've learned a lot about the disease since. The key issue is always going to be breathing. That's usually the ticket in, and that's the first sign for most people that they're getting sick. So if you're having shortness of breath, you definitely should come to the emergency department and be evaluated. Maybe somewhat short of breath if your pulse oxygen measurements, the cutoff number we use is 92%. If it's higher than that, then you may not need to be admitted to the emergency department unless you have other signs or symptoms that might show up on a test. But a lot of healthy people that come to the emergency department who have fever and flu-like symptoms and feel like they're sick, we may screen them and evaluate them, but they're not necessarily going to be admitted. We may not even need to do any further testing, because if the oxygen levels are okay, The chest X-ray isn't going to give us new information. A blood test isn't going to give us new information. It's really all about the oxygen.
Very good. Let's move on a little bit to, to testing, and let me just make just a few comments, and that is the question of who should be tested or who should be considered to be tested. And basically, those are people who have symptoms of COVID, people who have had close contact with somebody who has tested positive for COVID, or people who are in jobs where they cannot socially distance, whether they're traveling or are going to be in some indoor settings that they can't avoid. So in order to be tested, there are different types of tests, two basic types of tests that are done. One is the gold standard of testing, which is called the PCR testing, or polymerase chain reactive testing, and that's a molecular test. And the second type of test is the antigen test, and those are usually rapid testing. Those are the tests that you can get back within a few minutes or hours. The PCR test, usually you get the result back in a day or two, depending upon how busy certain labs may be. So keep in mind that. I think the one caveat on the antigen testing is that if you have an antigen test and you test negative, there are a certain number of people who have false negative tests. So if you test negative, but you continue to have COVID symptoms, then I would strongly recommend that you have a follow-up PCR test in order to be sure that you are negative, as there are some instances of false negatives with the antigen test. Antibody tests are not to diagnose COVID. Antibody tests are to see whether or not you have had COVID in the past. So it's the antigen and the PCR tests that need to be done to make the diagnosis. The question of where you go to be tested, there are many different places now in Orange County where you can be tested. For instance, Hoag and a lot of their urgent care centers, they have the ability to test for COVID. And a lot of times, in a lot of places, you need an appointment. For the Hoag places, for instance, you can go online, make a reservation, set up a time. You may need to have a Zoom, if you will, a FaceTime call with a person at the site in order to get scheduled. But most of the places, of Hoag places at least, you can go on their website that Eric showed you and basically set up an appointment through them. Also, there are, if you're a resident of Irvine or you work in Irvine, they have appointments at the Great Park. There's appointments through the Anaheim Convention Center or the Orange County Fairgrounds, or various pharmacies have it. So there are a lot of different places where you can go to be tested. It should not be a problem really in getting tested. I want to move on to what a lot of people have questions about, and that are vaccines. And maybe Eric, you can run through for us what vaccines are out there, what's the different types, how they work, et cetera, whatever you want to talk about in vaccines.
Well, I'm going to keep this one brief, Jim. If you want to get into more details about the differences, we can. The differences aren't really that important. There are two on the market now. There's the Pfizer, which one that I got, Moderna. They're the only two that are approved so far, but there are some in the pipeline, the AstraZeneca, which I think is already out in Europe. Okay. Johnson & Johnson has one. There's a Novavax that's coming out. So, people say, which one should I get? And virtually all of the experts that I've read or heard answer that question all say the same thing. Get the first one that's available to you. They're all effective. I know that there was a lot of consternation last week when we heard that the the Johnson & Johnson vaccine was only 66% effective, whereas the Moderna and the Pfizer were 95%. So why the hell would you ever get the J&J vaccine? You want that 95% effective vaccine. But when you read through the details of what that actually means, part of it is that the J&J vaccine started its testing a little bit later, and it did start its testing, for instance, in South Africa was one of the areas that was tested as that variant that you've heard about was emerging. And that variant is a little more resistant to the vaccine. So it's kind of skewing the numbers. The Pfizer and Moderna vaccines were tested before those variants existed. So that may account in part for their better outcomes. But most importantly, the most important thing to know about it is that all of the vaccines prevent serious illness. So when they say it's 66% effective, that means a few people that got the shot got flu-like symptoms, mild illness, not sick enough to be in the hospital, not sick enough to end up in the ICU on a ventilator, and most importantly, none of them died, none. So the vaccine, in terms of preventing, all the vaccines in terms of preventing serious illness and death, they're all effective. So I wouldn't worry about when you show up and they say, this is the vaccine we have, then you go, no, 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 I want the other one. Take what you can get as soon as you can get it.
Questions that, let me mention, a couple of things. And I'll just go into just a little bit of detail on the vaccines. The Moderna vaccine and the Pfizer vaccines are what we call messenger RNA. The other vaccines have to do with adenovirus and attaching a piece of the coronavirus to that. But suffice it to say, as Eric said, they all work. Let's talk briefly about how you get a vaccine, because I know that there's been a lot of angst, if you will, about trying to schedule a vaccine. So what do you recommend, Eric? What's the best way of going about getting a vaccine?
Well, we have what we have. We have Athena, and we have, the Hoag link that I see somebody's put up in the comments, so you have that. We have the super pod centers at Disneyland and Soka University, and other vaccine sites are going to open up. I know in the Hoag clinics, I know a little bit about that. So you have to go through the process. You can't cheat. So if you're not in the group that has been approved to vaccinate and you try and get an appointment, you're not likely to get one. Now, some people have gotten lucky, and you hear these one-off stories where somebody took somebody to get their vaccine who was eligible, and they happened to get their vaccine. It just happened to be that they had more available that day than they'd scheduled appointments. These things come in big lots, and they have to be defrosted, which is one of the difference between the vaccines. The Pfizer is the one that has to be the coldest, and Moderna also has to be refrigerated. I think the J&J one doesn't to the same degree. So, for instance, a pharmacy that might be distributing it may have 100 appointments, but 110 shots. So you might get lucky if you're in the store and they say, oh, we have some extra vaccine if you want it. So those kinds of things happen. So if that's available to you, go ahead and take it. You're not taking it away from somebody else. If it doesn't get given to you, it may get wasted and nobody gets it. So there are actually medical ethicists like Arthur Kaplan who have addressed that issue. So don't cheat. Don't try to get to the front of the line. That's not fair. But if you happen to be lucky and the vaccine becomes available, then you can certainly take it. But otherwise, you have to go through the same process as everybody else, and that is to go through either the Athena app, or as the pharmacies open, their websites are going to have the ability to make appointments as well.
One of the things that I would strongly recommend, depending upon who your doctor is and who you have seen in the past. So from the county standpoint, it's going through the Athena app, which has been frustrating for a lot of people, but you got to just keep trying and keep going on several times a day if you can try to get into it. But if you're a patient at UCI, for instance, UCI has a certain number of vaccine availability also, and you can go through their website and their electronic medical records site and try to get on. The same would go for Kaiser if you have to be a Kaiser patient. And also from Hoag if you're a Hoag patient. And I assume if you're a patient at St. Joe's, you may have something at St. Joe's. So I would not limit your trying to one site. I would go on as many sites as you can and try to get in as quickly as you can. So that would be the situation with Hoag, for instance. If you're a patient of the Hoag Medical Group and you have a doctor in that Hoag Medical Group, by going online, that would be a way of trying to get on the list. What I don't know, and maybe somebody does, which always, sort of is a question, is for all those people that have signed up with Othina, how do they determine who's next in line? Is it strictly by whoever came on first? Is it strictly by age, whether the 79-year-old gets before the 77-year-old or whatever it is? And I haven't been able to find that out. And that's a question that I, sort of wonder about in regards to Othina. So if anybody knows that, please let me know. I think it would be interesting to find out. Let's go through a little bit. I know we have some slides or so on the tier system. As far as we know now that people over the age of 65 are eligible, but maybe Eric, or you can go through, here are the next phases, if you will, as far as who would then be eligible. So right now, we're in phase 1A, but also involving individuals 65 years and older. And there's a lot of controversy statewide as far as, and which will pass down to the county, as far as whether or not there's going to be any switching, if you will, as who would be next. So there is talk that people who are between the ages of 50 to 64 may get in line sooner than some of the other people who may be in the tier 1B. So my recommendations would be to keep track of what the current situation is, and there'll be plenty of, let's say, there'll be plenty of time, that people will know who is going to be next in line when the next phase will open up. So that would be the situation of priorities, and you can see that. Now, there was a question that was asked as far as what you bring to a site in order to get your vaccine, and whether or not you're over 65, or whether or not you're an employee of, let's say, a preschool or a teacher, et cetera, et cetera. So Julie has just put up what you should bring with you. So you need proof of the appointment, Orange County ID. You don't have to pay for anything. I think that if you are not an age-related aspect, but it's something of how you, what your employment is, you may want to bring a pay stub that shows your employment. That may be what you need. As they say, employee badges, et cetera, et cetera. So that would be the situation of what to bring. Eric, why don't you, if you don't mind, talk briefly about the variants that we have, COVID variants from England, Brazil, South Africa, and what they mean.
Yeah, I read this. There's one in Los Angeles now. So.
That's right. Cedars-Sinai just announced that they've done studies that shows there's a new one, that a third of the people in Los Angeles have been infected with LA's own variant. So,
okay. So to Before I start down that road, I just want to remind everybody that I'm not an immunologist, I'm not a virologist, I'm not an infectious disease specialist, so I'm not really an expert. I'm out there and I'm working and I'm seeing sick patients, many of whom have COVID because they come to the emergency department, and that's my job. And I've made it a little bit of my business to try and be as up to date on all this stuff as I can. But I'm not an expert, but I'll give you my dumbed down, not for you, but dumbed down for me, understanding of how the mutations work. And Jim, because he's a brilliant internist, can kind of fill in the blanks here when I'm done. So viruses mutate. It's just what they do. It's a survival mechanism for them. And what tends to happen is viruses mutate. They do it for their own survival. If the viruses are killing the host, then the virus can't survive itself. The host dies, the virus dies with it. So mutations typically tend to be less lethal, less virulent as they develop over time. So that's kind of the good news. The bad news is that because the virus is mutating to help preserve and propagate itself, it does find ways to be easier to spread. And that's the danger of what we see. So you can have a virus that's 50% more lethal than the original version of it, and it may cause some thousands of deaths, but it'll be perhaps limited to a smaller number than a virus that is 50% more spreadable, because now you're going to spread this less lethal virus over a much larger population, and in that population you're going to have vulnerable individuals who are going to get very sick and die. So the real danger of the mutants isn't that it's a more serious, deadly strain, it's that it's easier to spread. So all of these mutations seem to share that in common. They seem to be more easily passed from one person to another, and that's the danger. So the good news about that, if this is good news, is that the things that we can do to control the spread of the old version work on the new version. So if you're wearing masks, if you're keeping social distancing, if you're avoiding large gatherings, you're not going to be in the situation where you're likely to pick it up. So you just have to continue to be careful. And as we roll the vaccine out and more people get vaccinated, the ability of the virus to find hosts to spread to will also diminish. So yes, the variants are worrisome. We have to take them seriously, but we don't have to panic, because we still have the ability as individuals and groups and as communities to control the spread.
I think also there's a lot of talk now that if there's a variant that becomes more deadly or spreads and it becomes a big issue, the vaccine makers are able to readjust, if you will, their vaccine. So it may be such that we may find in 6 months, people will need to have a booster, and that booster shot may in fact take care of that variant. So that's something that we don't know yet, but something that is quite possible in the future.
Right. And Jim, a couple other quick things on that.
Yeah.
So although some of the variants, like I think maybe the South Africa variant or the Brazil variant, may be more resistant to the vaccine is still pretty effective against most of them. I read this morning, I think in the New York Times, that there's been no evidence that the vaccine is less effective against the British variant. So with the tweak that Jim just talked about, the booster that people may get in a few months, if it's necessary, that will very likely be available, because now the technology exists to make those adjustments. The other thing I want to mention, again, because the importance still is controlling the spread. If you can control the spread, then we have more time to suppress the variants and keep them from getting out there. The mitigation measures of masking and social distancing are working. And one reason we know that is right now we should be in the middle of influenza season. I mean, this is flu season. And this, for me in the emergency department, is typically my busiest time of year. But we are seeing, because of flu, but we're not seeing flu this year. I don't think I've seen a single case. And it's because viruses don't spread when people keep distance, wear masks, wash their hands. And so what's working against COVID has been enormously successful in keeping us from having the double pandemic we feared we might have if we had a flu crisis at the same time we're having the COVID crisis.
What I think would be good now is to move to some of the questions that we have. And let me start, Eric. I have a few questions that were sent in before the Zoom here today, and I'll start with some of those and we'll go through them. The first one would be, if you've gotten the vaccine and you're exposed to somebody with COVID, what do you do?
I guess, I mean, you don't do anything a whole lot different. I don't think they're recommending you go into quarantine. I mean, obviously, if you know somebody has COVID, then you should stay away from them. But if you were inadvertently exposed, overwhelming odds are that you're protected. I've only heard of one case, and I think it was a congressman who, after his second vaccine, actually caught COVID. It's still obviously theoretically possible because none of the vaccines are 100% effective. So I think you take precautions. We still don't know for sure that being vaccinated prevents you from actually carrying the disease and giving it to somebody else. So you probably should, quarantine for a few days. But I don't think you need to go to the same extent that you would if you hadn't been immunized. You don't want to be reckless, but at the same time, you have to be smart and careful. So we will have more information as more people are vaccinated as to whether people are potential carriers. With other vaccines, it doesn't seem to happen. So we think that we're going to be okay in that regard. So the risk is low.
The risk is low, but I think you're right. I think we'll have more information. It would seem to me that if you know that you've had contact with somebody that has had COVID, that you should have a test. That you, after 3 or 4 days or 5 days, after having that contact, you should probably do a COVID test in order to see whether you have it. But I think you're right. More information will come out in regards to that. What's the protocol? What should you do after you get the vaccine? What other measures should you take? I think everybody, government-wise, basically talks about still wearing a mask, social distancing, etc. Is there anything else that you need to do other than that after getting the vaccine?
I got my vaccine and I have not changed my behavior at all. I still wear masks. If I see a very high risk COVID patient in the hospital, I put on the full garb. Because again, it's still too soon to fully understand what might happen. I do it partly out of respect to other people. I don't want to be the only guy in the room saying, haha, I got the vaccine, you didn't, so I'm going to be a jerk and do that. So we don't do that. But again, because of some of the unknowns about whether I could be exposed to somebody and inadvertently pass it on to somebody else, whether it's for a few hours or a few days, we just don't know. So it really shouldn't change anything until we've reached herd immunity, at which point it's going to be very difficult for the virus to find hosts to go to, and we can start getting back to more normal behaviors. So that's really the key. So between the time you get your vaccine and the time everybody gets their vaccine, really isn't going to change much.
So grandparents who now haven't seen their grandchildren for a year and have now gotten their vaccines and are anxious to see them or to spend time with them, it would seem to me the right thing to do is to practice social distancing and wear a mask, but you can now see them other than on FaceTime. That would be, I guess, my take on that. what about side effects from the vaccine? What can one expect? How long do you think it would last as far as side effects?
Well, most of the side effects when people get them are minor, and most of them occur within, you know, 24 to 72 hours. I suppose it's still possible to get, side effects afterwards. But that would be, more of a one-off. It's not likely. I was very lucky. I had virtually no side effects other than I got a little bit lethargic towards the end of the day, but sometimes I feel that way anyway. It was a little bit more, so I'm pretty sure it was the vaccine. I know a couple of physicians who were vaccinated who actually got a full-blown flu syndrome lasting 24 to 48 hours with, fever of 103. But again, that was a very tiny number of people. You've probably heard or read that there was a physician in Florida who had a weird issue with platelets sometime after he got the vaccine. And although it's not been, proven, many people believe that he had a fatal reaction to the vaccine. In Fountain Valley, there was a healthcare worker who got very sick within just a couple hours of getting the vaccine. And again, there's no definite cause and effect, but I just want to make sure people understand those are very, very, very rare events. And if you just do the simple math, if you look at, 25 million Americans had COVID, and of that 25 million, 440,000 died. About 25 million people have received the vaccine, and we don't know if anybody died from it, but the few that they're even thinking about, you can count on one hand. Your likelihood of getting very sick and dying from COVID is far greater than having any kind of serious reaction to the vaccine. So I would not let fear of side effects or adverse reactions or death from the vaccine deter you from getting your appointment and your vaccine. If you're in a special group, for whatever reason, your doctor, you've got some weird immunosuppressive disease, or your doctor is telling you, I don't want you to get the vaccine, talk it through with him. But in general, for most of us, none of those things should be an issue.
Yeah, I think I would stress that having side effects for a day or two or three may very well be due to the vaccine. But if you're having symptoms of whatever it may be a week or two after the vaccine, I would strongly recommend you speak to your physician, because it's more than likely not due to the vaccine as opposed to be from the vaccine. So let me turn it over to Jerry or Julie or whoever else has, some of the questions, and we'll run through those as long as we need to.
I got quite a few questions lined up here. Following a second vaccine, how soon is it safe to travel on an airplane?
Well, here's my take on it. First of all, after getting a vaccine, it usually takes about 2 weeks, 10 days to 2 weeks, in order to develop significant amount of antibodies. So one would say that it is relatively safe to travel 10 days to 2 weeks, let's say 2 weeks after receiving the vaccine. Still, you want to take all sorts of precautions, going to the airport, being on the flight, etc. The issue that you may have international travel is whether or not the country that you're going to, or if you're going, let's say, to Hawaii or someplace within the country, but let's say internationally, whether you can be admitted to that country, if you're not a resident of that country, and whether or not you need to quarantine going to that country. And then also, a lot of places require COVID testing within 3 days of traveling. And then some of them may even require COVID testing after you arrive at that country. So that I would recommend that there are specific requirements depending on where you're going. But the general question, I would say, would be 2 weeks after receiving the vaccine, it would be relatively safe to travel.
Yeah, and I would agree with everything Jim said. One thing about airplanes is they've got these incredible circulation systems, which are very helpful. we now have a federal requirement that you have to wear masks on the plane and in the airports. And all of those things are going to help. You just need to, amp up your precautions that you're taking, even though you've been vaccinated. It's not 100% certainty, and you want to just avoid risk as much as possible. I know that Hogue just opened a rapid testing center at John Wayne Airport. I haven't actually seen it, but I understand it's up and running. And so for the airlines that do require a COVID test, I know that's available. So yeah, you just still have to be careful. The vaccine is not going to be a guarantee again until we reach herd immunity.
Okay, thank you. Lots of really important information. Some of these questions have been answered in your talk, so I'm skipping those. If one has gotten the BAM, when can we get the vaccine?
I'm sorry, if one has gotten the what?
It says BAM. I'm wondering if they mean monoclonal antibodies.
They do. Bamlanivimab. We call it BAM for short. So,
Oh, okay, BAM. Okay.
so there.
Mhm.
I haven't seen a specific recommendation. Maybe I'll just take a quick peek. But my understanding is it's going to be less related to when they got the antibody and when the timing from their symptoms is. But I'm just going to double check and look at one of my sources here to give you a better answer.
Well, you should wait. Is it 10 days or 2 weeks after having first being diagnosed with COVID before you should consider getting the vaccine? But I don't know the specific answer to the question in regards to after the monoclonal antibodies.
Okay, so I just found one site that says you should wait 90 days. And 90 days was the recommendation that early on they were recommending that if you had COVID, that you would wait 90 days before you got your vaccine. But they changed that very quickly. So now they're just saying when you've met the criteria for coming out of isolation or quarantine, you can go ahead and get the vaccine. So this one says 90 days. Let's see if I can find another one.
Jerry, find out who wrote that question. We'll try to
Okay.
get back to them with a more
Okay.
specific answer.
I have that information. The next question is there any benefit to taking zinc and extra vitamin D on a daily basis?
I would say, I'll go out on a limb and say no, but at least I wouldn't say that it's necessarily recommended, but I don't know if there's any scientific studies that have shown that it is beneficial, but I defer to Eric on that.
Okay. I don't think there's any evidence that proves that those things make a bit of difference. There is an association of low vitamin D levels in people retrospectively found to have gotten sick. So I don't think it hurts. I'm not recommending it. I don't know that you need to, run out and stock up on it. If it makes you feel better to take it, like I said, there's not a lot of downside. But I agree with Jim. There's no evidence that it actually does anything.
Okay, thank you. The next question is, will I be allowed to get my second vaccine at Hogue if I got my first vaccine elsewhere, as long as it's the same brand?
Yeah, I believe so. I think you just have to show up with your card, with your appointment.
Okay, good.
I'm not so sure. I would check with Hogue in regards to that. I know for a fact, I got my first vaccine at Disneyland, and I asked the people at Hogue, could I get my second vaccine at Hogue? And the answer was no. So that may have changed. That was very early when Disneyland just first opened, and Hogue was just starting to do the vaccines. They had just finished doing the ER physicians, etc. So I'm not so sure about that. And I would follow up with the place that you want to go to see.
Yeah, generally when you get your first vaccine, they will give you an appointment for your second vaccine. So in all likelihood, it'll be easier to get it at the same place. I'm unaware if you're prohibited from getting it at a second place.
No, it's not a question of being prohibited. It's a question of what the policy is for that other place. Now, if you get it at through Athena, and you, let's say, get it at Disneyland, and now all of a sudden the Great Park in Irvine opens up a super site, or Soka, or some other county facility, you can, on the Athena app, reschedule your appointment for the second vaccine, and you may be able to switch to a different venue within the Athena vaccine site.
Okay, so Jim, I'm going to tell you you're absolutely right. I just looked at the Hoag site and I was unaware of this, but somebody asked the same question. I received my first dose through the county. Can I come to Hoag for my second dose? It says no. Individuals who received a first vaccine through the Athena system will get an email notification 3 to 5 days before the second one is due. And so they are saying you need to get it through the same source. So Jim, you are correct.
Thank you very much. This question's about herd immunity. How will we get herd immunity by June if younger people in their 40s aren't getting vaccinated?
Well, that's a good question, but again, looking at the graph, it's an issue with the total number of people in the population who get their shot. And the estimates of herd immunity somewhere maybe between 65 and 75% is sort of the target for what you need. There will be a lot of people for either political reasons or conspiracy reasons or anti-vax reasons or fear who aren't going to get it. And if that number exceeds 30 or 40%, then we may take a much longer route to getting to herd immunity. So it's a good question, but I think overall the indications are that there will be enough people who will either get antibodies from getting sick or antibodies from vaccination that will allow us to achieve herd immunity. And June is very optimistic. That one model said it. A lot of people are saying late summer is more realistic. I'm going to keep on the optimistic track, but and still encourage everybody to go out and get the vaccine because that's the quickest way out of this.
Yeah, let me just chime in today. On TV, at least, the Biden administration has put forth and said that they expect anybody who wants a vaccine should be able to get a vaccine by the beginning of summer. I think that's, again, optimistic, but that at least they're on record of saying that at least.
True, but Jim, also remember that we're having more vaccines in the pipeline that will be easier to distribute.
Correct.
And the J&J vaccine, for instance, is a one-shot vaccine.
Exactly right. Exactly right.
I think that the optimism is still well placed. I think it's aspirational, but it's not crazy.
Okay, our next question is, we're scheduled to get our second shot in about 2 weeks. What are things we can do safely as we wait for herd immunity?
That's easy.
Yeah.
Jim may want to answer it differently, but I would just say wear your mask, keep social distance, avoid large gatherings, no Super Bowl parties this weekend, other than with your immediate family, which Dr. Fauci's recommendation was specifically. You got to do the same things. And most of you made it through, the last year so far doing those things and not gotten sick. Not all of you, but it can be done. And, when I talk to people who got COVID, it's usually, well, I thought that person was okay, or I thought it was okay to do this, but it clearly was outside the guidelines that are set. So you do the same thing. That hasn't changed. But I'll see if Dr. Brenner wants to add anything to that.
So the next question is, if you've had COVID, can you still be a carrier for the variants or a carrier of COVID?
Say that again, Jerry, I'm sorry.
If you've had COVID, can you still be a carrier of COVID or the variants?
In other words, if you've had COVID, can you get reinfected with the variant strain of COVID? I guess that's
Yes.
really the
To
question.
pass that on,
You know.
yes.
And I guess the scientific answer would be yes, you could. You could. And there are very rare instances of reinfection presently, but they're very, very rare. I think it's far too soon to really consider all that. But the specific answer is yes, you could have had COVID and you could now be infected with a variant of COVID, just like you've been vaccinated and you can get infected still with a variant of COVID. But hopefully the idea would be, I think, a similar situation. Hopefully, if you've had COVID, you have developed antibodies to that strain at least. And there may be some cross-reactivity with the new variant such that it would be less likely for you to be very seriously ill or die from that new variant. But I assume it's theoretically possible.
Yeah, and I would agree with what Jim said on that. That you very likely have immunity, and you're not likely to get that sick because you're going to have antibodies. You know, I don't think they've identified any mutant strain yet that is going to overwhelm the vaccine or people who have had immunity from being sick before. So, but again, we still don't know all the answers yet, and we don't know what variants haven't appeared yet and will appear between now and the time we reach herd immunity. So that's why all of the other mitigation precautions remain so important to do. And while I have the microphone here for a second, buried in the CDC website, I did find the answer to the question about those who've received BAM or the monoclonal antibody. And the recommendation is that they should wait 90 days because they really haven't studied it yet. And they think that if you've gotten either the monoclonal antibodies or if you're one of those who've gotten sick and were treated with plasma containing somebody else's antibodies, the best thing to do is to wait 90 days and then get your vaccine.
Great, thank you for finding that out for us. I had a question on the Moderna lot. There's a number there, I think it was 041 L20A. Because there was so many reactions, and I guess they pulled that off availability. But it says, why is it still being given? I don't know if it is. Do you know anything about that?
You know, I saw stuff in the news when it first came out that there was a particular lot that several people, I think mostly in San Diego, got sick from right after they got it. And they were healthcare workers that was early in the Moderna distribution, and they just pulled that lot entirely. I never really heard what the outcome of it was, but I doubt that lot is still being used. I mean, it was a specific, clump that was manufactured in a certain place on a certain day. So I don't think you need to worry about that.
Okay.
I think the only caveat I would say is that when you got your vaccine, and if it was a Moderna vaccine, they put on the card the lot number that you did get. So if you're at all concerned, just look on your card, to make sure it's not the lot number that is, in the papers, basically, about it.
However, if you got your Moderna vaccine from that lot, a month ago when that happened, and you didn't have a bad reaction, you shouldn't worry about it at all. If you got it yesterday or an hour ago, yeah, you might be a little worried. Mm. But I don't think they're giving it out now. I think that lot's been pulled.
The next question is about the Orange County Healthcare Agency says they offer free at-home saliva tests. Would you rely on those?
it's a good question. And you can get tests from Orange County Health Department. And the answer to that is yes, you can rely on those tests if done according to the instructions on how to take the test, how to do the test, the tubes to put in, etc. So the answer to that is yes. But I want to bring up in regards to that another issue, and that is self-testing at home. I read yesterday or the day before that there's an Australian company, I forget the name right now, that the US government has just given over $200 million to produce these tests that people can do at home and get the result at home within an hour or so of doing the test. It probably will, it's not available now, but will be available over the course of the next few months. It may cost something around $30 per test, and that may be something that you may be seeing. Also in the works, a lot of companies are trying to produce even less expensive tests to do at home. And that's really, I think, the key in the testing long-term wise is to have tests that you can do at home, even on a daily basis or every other day basis, that will be very, very inexpensive, less than $1 a test. And that way you can do the tests at home and know whether or not you are positive or negative. But in regards to the question about the Orange County test, I think you do that. They send you the kit, you do the test, and then you have to take that kit to a lab, either Quest or LabCorp, I would assume, and they would then do the test on it. It's not a self-test that you do at home. You take the test, you do the swabs at home, but the test is actually done through a lab.
Okay, thank you.
And that I want to just toss one other thing in there. So way back last summer, there was a Harvard epidemiologist, his name was Michael Mina, I think, who was proposing widespread, cheap, at-home testing that you get the results instantly and all that. And even though these types of tests may turn out to be a little bit less accurate, the idea is if you're doing millions of these tests frequently, the likelihood that you're going to get enough false negatives that it's going to be a source of viral spread versus the idea that you're going to get true positives and mostly true negatives on this widespread basis is going to be an important step towards allowing people to get out. Now, this was all started before the vaccine, which is going to, again, be the most important thing. And over time, the widespread testing will be less serious, but for the near future, obviously, it's going to be important. So all of these tests, even if they're not perfect, if they're being done frequently in appropriate settings, especially if you have symptoms, when they're more likely to be positive, are a good thing.
Okay, thank you. Someone had a second vaccine and said, is it fully effective 2 weeks, 4 weeks after the second vaccine?
I think it's 1 week.
I think it's 10 days to 2 weeks. I think you start seeing antibodies, but the peak, or I don't know the peak, but my impression is 10 days to 2 weeks is the time frame.
Okay. Here's another question. My mom just got her first shot. Can I go visit her if I haven't had a shot?
So mom just got the first shot. I'm assuming
and the daughter doesn't have the shot. Can she go visit?
Okay, well, we'll have to follow up on what Dr. Berman just said. That I guess no, unless you do it just masked and everything else. It's no different than it was the day before she got the vaccine. It's too soon to have any kind of effect.
Okay. There's several new questions. Are you able to give us a little more time or?
Yeah.
Okay.
I'm retired, Jerry. I have all the time in the world. Yeah.
Okay, we can go on all day.
Well,
Especially since
no.
nobody has anything much planned these days. Um, there's a risk of is there a risk of reducing antibody formation by taking anti-inflammatories prior to the vaccination?
Okay, I'll sort of attempt to answer that. I do not believe if you're taking an anti-inflammatory such as Advil, ibuprofen, on that regards, no, I don't think that there's necessarily that risk. But if you're taking anti-inflammatories, such as steroids, prednisone, for instance, or you're taking some of these newer medications that you're using for rheumatoid arthritis or other problems, these monoclonal antibodies, basically, that you're using for treatment to decrease inflammation, then the answer is yes, it may very well have an effect on your production of antibodies. So if I think this is a question that I'm faced with, and I think people who may be on, not directly related to the question that you asked, but people who are on immunosuppressive medications, or people who are on chemotherapy for cancer, or people who have altered immune systems for one disease or the other, whether it's medications they're taking or the underlying disease, they are at higher risk of developing COVID. And there is concern as far as whether or not they will produce the same amount of antibodies after a vaccine as, quote, normal people, might form. So my strong suggestion is to speak to your physician about that, to see whether or not one has to take other avenues. For instance, and this is not by no means do I say that this is recommended or how can I say it, advised, if you will. But there are certain questions would be is, should somebody in that position be checked for antibodies at 2 weeks or 3 weeks to see whether or not they have formed antibodies, and whether that would be something that your doctor would recommend? Or it may be such that they may recommend you to have a booster injection of a vaccine a month later, or 2 months later, or 3 months later, if you are on immunosuppressive medications. So these are questions that I personally have thought about, but I don't want to say is dogma, if you will, or something that is recommended. But I would strongly recommend, if you are one of these people who are on immunosuppressive medications, or are actively undergoing chemotherapy, or have some other underlying immunodeficiency syndrome, that you speak to your doctor about and see whether or not something else should be done.
You mentioned boosters, and that made me think about people who didn't get the antibodies, or people who, well, just in general, may be prone to getting the variant virus. If there will be some kind of booster to enhance resistance to the variant viruses.
Right. Well, as we talked earlier, that may be something that may be recommended down the road. It certainly is not recommended now for the general population in regards to that.
Okay.
I'm basically talking about those people who may not form antibodies. They may still be relatively safe from developing severe disease. And the question becomes one of, if you have the vaccine and you have not formed significant antibodies, are you still protected from developing severe disease or not? And I don't know the answer to that. I don't know whether people know the answer. I'm sure that they're being studied. But I think that's something that may come down the road for those specific people who have known underlying problems.
Okay. There was a question about children getting the vaccine. Do you think that will happen?
Well, I think eventually it just isn't studied yet, but no, I think eventually it will be part of the process.
Yes, studies are being done now on that question. So we'll know that eventually. We know that children, especially younger children, are less likely to develop, COVID or symptomatic COVID, certainly. But I think that will be a question. I think the other question that people have is whether or not somebody who is pregnant, whether they should be receiving the vaccine, or not, and how safe is it? And I think that's something that should be discussed with their obstetrician to go through the pros and cons and risks involved either way. So I think that's another area that we're not completely understand, if you will.
The next question is, can you still infect others even after you've been vaccinated as, I guess, a carrier?
Again, I think we've talked about that a bit, that
Yeah,
we
we
just
have.
don't know for sure yet. So we still are recommending the precautions be taken after you've been vaccinated.
Yeah.
I mean, it's
yeah,
unlikely because it
two
doesn't
things
have
that we've
another
already answered.
Yeah.
Okay, I think let's see. Okay, I think we've answered all these questions.
Wow.
There's a new one that just came on. I didn't fully read it. Oh, so Dr. Berman, if someone's on an immunosuppressant drug, you're recommending that they get an antibody test to make sure that they got.
You're getting me into trouble, Jerry.
Okay.
The answer is I don't know.
Okay.
I don't know.
Okay.
However, I personally, I'll give you my personal opinion. My opinion is that I am on immunosuppressive medications at the present time. And so I plan on getting antibody tested 2 weeks or so after my second vaccination. And let me make one other comment, which is important. If you are getting antibody testing, if you do get antibody testing after a vaccine, there are two different types of antibody testing. One is antibodies against the spike protein, and the other one is antibodies to the nucleid. You want to make sure that you get the antibody towards the spike, antibody test towards the spike protein, because that is specific for COVID-19. If you get the antibody related to the capsid, or you get the antibody related to the nucleid, that may have cross-reactivity with other coronaviruses. And since there are many different coronaviruses, you may have antibodies to that test, but that's not specific for COVID-19. So if you do get antibodies, I would make sure you get it to the spike protein.
So Jim, that was a very smart and scientific answer. My answer would have been a little bit different, and that is that if you're taking an immunosuppressant medication and there is a doctor who is prescribing it to you, and it's a discussion that you should probably have with that doctor, so you're doing the right thing, because the doctor prescribing those drugs probably know quite a bit about that, as much as anybody else does, but there's still a lot of information none of us know. But that's where I would start.
I would agree totally. And I would specifically say, don't tell your doctor that Dr. Berman recommended it.
Okay.
Trying to keep you out of trouble, Jim.
Okay.
But that was a great answer.
What's said here stays here, okay? So I really want to thank you both. This has been tremendous and terrific. So much information, so much insight. I can't thank you enough, and I'm sure our members feel the same way. And we just want to say thank you, thank you, thank you. And we really appreciate you both. And that's it. So we'll just say so long. If I guess if anybody wants to contact me about anything concerning this talk, please do. And otherwise, we'll see you soon. Hopefully back at the J. Wouldn't that be nice? Maybe over the summer.
That would be very nice. Thanks,
That's
Jerry,
what
for
we're
putting
hoping
it on. Jim, thanks again for doing this with me, and thanks to all of you guys for being out there and doing the right thing and trying to get this under control so we can all get our lives back and meet at the J in person. So
Yes.
Right. Thanks, Eric. Thanks,
Thank
Jim.
you.
Jim, Eric, thank you. Thank you, guys.